You are now listening to Nailed It, the Orthopedic Surgery Podcast.
A case kind of made up is, say, for example, 15-year-old gymnast who's been practicing for months nonstop, high-level athletes wanted to make the Olympic team. It's brought to you by a parent who states that recently she's just kind of being more tired and lately and just complaining of just increasing wrist pain. And you mentioned a little bit earlier about the female athlete triad. Can you kind of, take us through what are some of the things that you'll see in patients that have this triad and what exactly the triad is?
Right. So yeah. So again, when this was originally described, it really did. We were, as medical field, we're focused on the extremes: anorexia, amenorrhea, and osteoporosis. And with time, again, it's the spectrum actually is the more important thing to understand, that you don't have to have complete absence of menses, but having irregular menses is important, right? And that raises a red flag. To have, not to be anorexic, but to just have low energy availability. And then with osteoporosis, right, not having that extreme form of low bone mineral density, but just being lower than would be expected for your age. And the underlying issue in all of this is low energy availability, because without enough energy, that affects the hormonal fluctuations. And so in turn, our female athletes will then have irregular menses. And without the normal fluctuations of the hormones, then we don't have normal development of bone. And unfortunately, like the time period when this is most often occurring, which is teenagers, up through early 20s, so our high school and collegiate athletes, that is the time when we maximize our bone density. So for our athletes that are suffering with low energy availability, irregular menses, et cetera, and are not making enough bone, they're never going to achieve what would have been their maximal bone density. And then starting at about age 20, early 20s, the bone density starts to go down. Now, it's not precipitous, but that goes down with time. And so we really need that peak to be as high as possible, so that when the normal changes throughout the rest of our life happen, that they're starting with a good bone density, and that decreases the risk of fragility fractures down the road.
Right. And I love how you just kind of explained all of that and broke it down. Of course, number one, the low energy availability being the main one of the main things and the main problems, which can lead down the line to impaired bone formation. And if that continues on down the spectrum, it can lead to kind of osteoporotic, or fragility fractures or fragility injuries. And for those listening that have not looked at an OBGYN book in years, just to kind of just go over what a little bit about the menstrual dysregulation. So primary amenorrhea, kind of just, when you haven't had a period, and then secondary amenorrhea is when you were menstruating beforehand and then you don't have a menstruation cycle for a couple of cycles. And then oligomenorrhea is when you have a cycle length greater than 35 days or less than 9 cycles a year. And so these are some of the things to be on the lookout for, when you're asking, or when you have these patients in your office and you're trying to figure out, where they are, I guess, on that spectrum that you talk about. Now, for the low bone mineral density, how often do people really get DEXA scans? Like, is that I know that's the way that we measure the bone density, but do you get a DEXA? Have you ordered DEXA scans for these, or you kind of just look at X-rays and kind of just look at their bone quality? Like, what do you actually do?
So that's a great question. Certainly in our elderly patients, we get DEXA scans, and that's how we diagnose low bone mineral density or osteoporosis. In our young athletes, we do not routinely get DEXA scans, but what I would say too, and I will complete this discussion, but I just want everybody to know too, I don't ask all of my female athletes about their menstrual history, but if there's any concern and I think it's related, I will ask them. I just ask them, are you having regular periods? And you can imagine, for a 14, 15, 16-year-old girl, she might think it's cool that she doesn't have a period every month, right? Oh, this is so great. Like, it's not a good thing. And so that is part of our job as orthopedic surgeons. And we want both our male and female orthopedic surgeons to feel equally comfortable asking these questions, because we may be the first physician seeing these athletes, and we may have the ability to diagnose it, diagnose relative energy deficiency in sport, diagnose this irregular menses, and get the athlete to the right person. So when there's any concern, I will ask those questions. I have no qualms. I'll ask in front of the patient. Usually the parents are there. If the athlete doesn't feel comfortable for whatever reason, the parents can leave, but it's usually a non-issue. I mean, these questions are asked in a non-threatening way. And the most common scenario in which I would feel, I would think to ask these questions is if an athlete's presenting with shin pain. So I'm concerned either about shin splints or a possible stress fracture, right? That is one of the most common presentations of relative energy deficiency in sport or female athlete triad. And so that's where I'd start asking those questions. And if I have concerns, if they say, well, yeah, I've a couple months in a row, then I don't have it for 3 months, then I have it for a couple months, I would actually refer that patient to an OBGYN physician. And fortunately, we have a great network here at Tulane that we've developed. So I know right where to send the patients. Additionally, if I have any questions or concerns about their nutrition based on our conversation and just kind of getting an idea of the types of things that, our 15 or 16-year-old athletes are eating, I would then send them to a sports nutritionist and potentially even a counselor. Like if I'm really concerned about a potential eating disorder or some restricted eating or some abnormal eating habits, I would refer to all of those people so that athlete can actually get the appropriate evaluation and the appropriate care. I mean, I feel very comfortable diagnosing these things, but then these are the specialists to actually treat the athlete.
That is perfect. You took all the questions I was just about to ask you about it and answered them already. So I love